Hello, my name is Carina Rodriguez, and I'm presenting in place of Eva Natakunda, who could not be here today. On behalf of my co-authors, I would like to present our presentation entitled Preliminary Safety, Efficacy, and Acceptability of Bictegravir, Emtricitabine, Tenofovir, Alafenamide in infants and children from 1 month old, weighing 6 to less than 14 kilos. We extend our thanks to the Congress organizers for inviting us to present this data. My disclosures are reported here. Despite recent improvements in HIV treatment, infants and children with HIV have limited treatment options and often face a high pill burden and non-pediatric, poorly palatable formulations. BF-TAF is a single tablet regimen containing an unboosted integrase strand transfer inhibitor, Bictegravir, co-formulated with the nucleotide reverse transcriptase inhibitors, Emtricitabine and Tenofovir alafenamide. BF-TAF has a high barrier to resistance and is efficacious and well tolerated. BF-TAF is approved in the US for children from 14 kilograms and in the EU from 2 years and at least 14 kilograms. BF-TAF has now been formulated as a lower dose tablet for oral suspension or TOS for children who cannot swallow tablets. Here we present preliminary safety, efficacy, and acceptability outcomes in children with HIV 1 month and above and weighing 6 to less than 14 kilograms who are treatment naive or on antiretroviral therapy at the screening. Our objective was to evaluate preliminary efficacy, safety, and acceptability of a BF-TAF tablet for oral suspension in this population. Data are available after all participants had completed the intensive pharmacokinetic evaluation visit at week 2, and over half of the participants had completed the week 12 visit. The data we present is part of a phase 2-3 open-label, multi-center, multi-cohort, single-arm study to evaluate the pharmacokinetic safety and efficacy of BF-TAF in children and adolescents. This analysis focused on participants who were treatment naive or experienced at the screening and enrolled in cohort 4, groups 2 and 3. Participants in group 2 were at least 1 month old, weighed 10 to less than 14 kilograms, and received 2 BF-TAF tablets for oral suspension, each containing 3.75 milligrams of Bictegravir, 15 milligrams of Emtricitabine, and 1.8 of TAF, twice daily. Participants in group 3 were at least 1 month old, weighed 6 to less than 10 kilograms, and received 1 of the same BF-TAF tablets for oral suspension twice daily. The tablets for oral suspension are formulated with a berry flavor to mask the bitterness of TAF and are suspended in water and administered using a cap or a syringe. The study design is shown here. PK efficacy and safety data for full-strength BTAF in adolescents aged 12 to less than 18 years of age in cohort 1 and children 6 to less than 12 in cohort 2, and for low-dose BTAF in children 2 years and over in cohort 3 had been previously published. Cohort 4 is evaluating the BF-TAF tablet for oral suspension in children who cannot swallow tablets. The analysis presented here are focusing on the groups 2 and 3 of cohort 4, on which include children 1 month and above who weigh 10 to less than 14 kilograms and 6 to less than 10 kilograms respectively. There are 14 patients in group 2 and 15 in group 3. An intensive PK assessment was carried out at week 2 and dose assessed after 7 participants had completed the intensive PK visit. In group 2, the median age was 30.2 months and the median weight 11.3 kilograms. While in group 3, the median age was 8.9 months and the median weight was 8 kilograms. Approximately half of the participants in group 2 were female and about 3/4 of group 3 were female. Most participants were Black and acquired HIV vertically. While approximately half of the participants in both groups were not virologically suppressed, the median and in-quartile range for CD4 count in cells and percentage were within the normal range. The median exposure to BF-TAF was 54.5 weeks for group 2 and 32.7 weeks for group 3. Our preliminary results show that the percentage of participants achieving viral suppression increased from baseline. The lighter blue or red are those that started suppressed and continues through the study. Overall, absolute CD4 count remained stable, while CD4 percentage increased from baseline as seen on the right side. 43% of participants in group 2 and 93% of participants in group 3 had at least one treatment-emergent adverse event. All treatment-emergent adverse events were grade 1 or 2, apart from one report of a grade 3 increase in blood alkaline phosphatase in group 2, which was transient, and one serious adverse event of grade 3, which was a case of malaria in group 3. Only one adverse event was considered related to study drug by the investigator. This was of grade 1 pruritus experienced by a participant in group 3. No adverse events led to study drug discontinuation. The only grade 3-4 laboratory abnormalities detected in more than one participant was increased amylase, and this was experienced by 4 participants in group 3. All 4 of these participants had grade 2 or 3 amylase prior to BF-TAF initiation, and the increases were transient and asymptomatic with no graded lipase throughout follow-up. Overall, glomerular filtration rates in both group 2 and 3 remain stable, and variations are consistent with the known renal creatinine transporter effect of bictegravir and not considered clinically significant. We perform tablet for oral suspension acceptability and perceived palatability assessment by caregiver questionnaire. Most caregivers reported that they were easy to prepare and had favorable palatability to the child. In summary, this preliminary analysis of BF-TAF in infants and children from 1 month and weighing 6 to less than 14 kilograms demonstrated favorable safety and efficacy for the newly formulated BF-TAF for oral suspension. It was well tolerated with no grade 2 to 4 or serious drug-related adverse events. Most participants achieved or maintain viral suppression. Ease of preparation and palatability were rated favorably by caregivers. These data support further evaluation of BF-TAF for oral suspension in this population. Additional analysis, including assessment of pharmacokinetics, efficacy, and safety, will be conducted at week 24 and 48 of treatment. We hope to return at future workshops for additional data from these groups, including participants in group 4 weighing 3 to 6 kilograms. On behalf of myself and my co-authors, I would like to thank the participants, study investigators, and staff for the involvement in this important clinical study. These studies were funded by Gilead Science, and I appreciate and thank for your attention.